This is Going Under, Anesthesia Answered with Dr. Brian Schmutzler. I'm Vahid Sadarzadeh. Hello, good afternoon.
Good afternoon.
And welcome to episode 7 now of Going Under, Anesthesia Answered with Dr. Brian Schmutzler. Of course, you send in your questions to him on social media and on his website, and he does his best to answer pretty much every single one of them regarding anesthesia and regarding healthcare as well. And today is one of those days. And in this episode, Brian, today we're going to discuss all about how insurance works, because I think there's a few misconceptions out there regarding, how is insurance? How do physicians get paid? Yep. That sort of thing. So let's just break it down. And first and foremost, really, how does health insurance work?
Yeah, so just a general idea of how health insurance works. So companies or Medicare, Medicaid, they pool all the money that comes into them as premiums, right? So that's what you pay every month through your employer for United Healthcare or Blue Cross Blue Shield, or if you pay a Medicare supplement plan. So all that money goes into a pot, and then when services are needed, that money gets paid out of that pot to a hospital, to a provider, to whatever, a facility, whatever the case may be. And so the way that works from a provider or from a facility end, let's say you come in and you have an anesthetic with me. I'll take that particularly billing sheet. We'll bill it out, and we'll talk specifically about anesthesia in a couple minutes, but I'll take that sheet, and then I will pass that along to that company, whatever it is, Medicare, Medicaid, the insurance company. Somebody on their end will look at it and decide whether I billed it and coded it right. And if I did, they'll take a little bit of time to figure out where the money goes and how to pay it and how much they're going to pay. And then eventually they'll send that money to our practice as a payment for, in our case, professional services or for facility fees for the services. And so the whole premise behind insurance companies, not necessarily so much Medicare and Medicaid, but the insurance companies, is that they take a pool of money in premiums and they expect to pay out less than they take in, and that's how they make profits. Some of them make more, $4 or $5 billion a year. Some of them make less. And so it just like any other insurance, the premiums are supposed to cover the cost of the claims plus a profit for the company. And so that's kind of in general how insurance or health insurance works. Now, when it comes to anesthesia, there's a lot of specifics. So when, let's say, your surgeon bills a procedure, they bill it under what's called a CPT code, or basically a procedural code. Anesthesia is billed differently. We bill our time in not only what we do. So let's say you have your appendix out. There's a code for that. We get a base amount for that. But then anesthesia is also billed on time. So for every 15 minutes, we get an additional what's called a unit. And so each payer, Medicare has a specific rate. Each payer has a negotiated rate. So for instance, if you have your appendix out, that might be, so appendectomy, I think, is a base 6. And then let's say it takes an hour, so that's 4 more units. So that's 10 units that I'm going to bill, and I'm going to send to the insurance company, and they're going to pay me those 10 units times whatever rate they decided they would pay me per unit, and that's how much they'll pay for that particular procedure. And so when you get your bill from a surgery, you'll get a few different bills. You'll get the bill from the surgeon, right? That's a professional fee. You're going to pay him for what he did. You're going to get the bill from the facility. That's called a facility fee, so a hospital or a surgery center. And then you're going to get a separate bill from the anesthesia, and that's a professional fee as well. So most of the time, if you have a surgery, you're going to get 3 separate bills. Even if it's fully covered through Medicare or Medicaid, you'll still see 3 separate bills from each of those 3 separate pools.
So I have a lot of questions.
I'm sure you do. It looked like you had some questions.
My wheels are spinning on this insurance thing. So let's break it down into like cost, right? And maybe an example.
Sure.
So let's say I have surgery on my wrist. Okay. And I need full-on anesthesia. You need to put me under. So let's say, they don't always give you the company will pay for it or whatever, right? Like, it's always most likely they will cover it.
Right.
But you have to send it in anyway.
Right.
So does the insurance cover every single one of those three that you said, the anesthesia, the facility, the procedure?
It depends if they deem it medically necessary. So this is a game that the insurance companies play where they say, well, it wasn't medically indicated, or you didn't get a prior authorization for that, so you're on the hook for it. In general, if you have appendicitis and you go to the hospital to get your appendix out, the insurance company is going to pay for each one of those portions. The surgeon's bill, the anesthesiologist or anesthesia provider's bill, and the facility bill. If you're having an elective procedure, something on your wrist, you're going to have to make sure that they get prior authorization. Now, we usually in anesthesia, with the exception of a few select type of procedures, in particular, anesthesia for pain procedures and anesthesia for ophthalmology and anesthesia for colonoscopies. Those are the three areas where we typically have to get a prior authorization as well. But any other procedure, if you come in and you get your wrist done, we don't need prior authorization for that. They understand that if you have your wrist done, even if most of the time, even if they don't authorize you to actually have the surgery done and you have to pay for that yourself, they're still going to pay the anesthesia bill.
Got it. So, okay. And then, what about, what about the insurance in terms of how they make the decision to pay it out or not? What's the criteria? Who makes that decision?
So I will speak just in generality about the insurance industry, period, and not about any specific company. But usually the decision is made by somebody on the front end, answers the phone and says, hey, Vahid needs his wrist worked on because he has pain in his thumb. Just making it up. And the person on the phone has an incentive in most cases, because most of the time they get a bonus based on denials, not based on actually.
Really?
Oh yeah. Now again, in general,
right? We're not talking
company in general, and this may be different now. I'm not in the insurance industry, but the insurance companies have a financial incentive for you not to have surgery, right? This goes back to the same idea of the insurance companies taking a premium. And whatever they don't pay out in claims is profit, right? So they have a built-in incentive not for you to not use your insurance, right? Okay, so it goes through whomever that is, whoever answers the phone, and they say no. Then it gets kicked back to the provider, whoever that is, whether that's anesthesia, whether that's surgery. And now I have to decide, am I going to call the insurance company and ask for what's called a peer-to-peer, okay? So a peer-to-peer is, I assume it's going to be an anesthesiologist, although they consider a peer any physician. So it could be a radiologist who's deciding whether or not they need anesthesia. And so then I have to talk to that peer, and I have to convince them that you need your wrist worked on, or you need the anesthesia for your wrist being worked on. And then if that gets denied, which, again, there's incentive.
It could be, right?
There's incentive for that, right? The insurance company makes money by you not using your insurance. So if it gets denied at that point, I can ask for another level up. And if it gets denied at that point, it's just denied. There is a report of a certain insurance company using AI to automatically deny claims. So that was an interesting article to read. I don't know whether it's true or not, but the report was out there. And I don't know exactly how it worked, but what I'm picturing is I call in for a peer-to-peer, and instead of actually having...
You talk to a robot.
Right. I talk to a robot instead of a physician, and I never know the difference. Now, that's not what the article said, but that's what I'm picturing in my head.
Let's go back to kind of how this all started. So, I mean, obviously somebody wanted to make money, right?
Sure.
And somebody had the idea of let's be a middle decision maker in all of this. Why not leave it in the hands, this may be a loaded question, and it may be a stupid question, but why not leave it in the hands of the actual providers, right? The hospital systems. Why go through these companies when the actual decision makers on doing these surgeries or procedures are the physicians or the hospitals themselves?
I mean, I would argue at this point we're not actually making that decision in a vacuum anymore. We don't get to make that decision without the approval of either an insurance company or Medicare or Medicaid, right? You're not going to have a surgery that's going to cost you tens of thousands of dollars if the insurance company says no. So in essence, I don't get to make that decision.
But even if it's coming out of my pocket or I'm not paying for it, though, Like if I'm paying for the surgery.
Yeah, certainly, yeah.
Yeah.
But if you want to come in and you want to pay cash for a procedure, who cares what the insurance company says? You can get that procedure done as long as it's medically indicated. So the way that I understand it is in the middle of the 20th century, call it the 50s, 60s.
Sure.
What companies did to retain their employees when they couldn't give them a raise was they started these benefits, right? That's where benefits came from. And so they said, hey, we'll pay a portion of this thing called health insurance so that you and your family are covered if something happens. So I can't give you a $5 an hour raise, but I'm going to cover this. And at the time, it was super inexpensive because the insurance companies weren't making a ton of money, and it was just kind of a new thing. Now that ballooned over time, and you can look at all the changes. You can look at the Medicare and Medicaid acts. You can look at the you can look at all of the ways that other benefits have come along. You can look at the ACA, the Affordable Care Act in 2010, I think it was 2008, 2010. That's fundamentally changed the way that insurance operates, and now you're required to have health insurance, right? If you don't have health insurance, you're penalized.
Right.
Yeah. And employers are also now penalized if you don't have health insurance, which is interesting. Anyway, we can get into that.
Yeah, rabbit hole, right? Yeah, exactly.
Podcast, but, so yeah, it was initially brought to employees by employers.
Got it.
As an incentive when you couldn't pay extra money to retain your employees.
So really interesting how it all started, right? I don't think a lot of people know that or have common knowledge of it. I certainly did not, right? We just kind of accept health insurance for what it is, right? It helps me lower the cost of my medical bills.
Sure.
What does that mean for you? What does that mean for the anesthesiologist? What does that mean for the providers?
Yeah. So that means a lot of headache. It means thousands, in some cases, hundreds of thousands or millions of dollars spent in billing, right? So, most practices have an entire department of billing on top of having their own billing company that they pay a certain amount to.
Sure.
And you essentially have to do this anymore because the billing and coding is so complicated, and the insurance companies will deny things for any reason. If you put if the person's name, I had this happen twice. If the person's name is, John Doe Jr., and it's JR, not J.R. and you put the dots in it, they'll deny the claim and make you resubmit it. So they're looking for absolutely anything to deny your claims. So that's a huge increase in cost, in time. It takes 90 to 120 days to get payment for most insurance companies. Medicare and Medicaid are a little bit better. Usually it's about 15 days, but the private insurance companies, 90 to 120 days to get paid. Which really is which is really difficult when you're trying to run a practice and you don't know when they're going to pay you. They could pay you in 2 weeks, or they could pay you in 6 months. Never know. Sometimes they just don't pay for whatever reason, or they'll deny a claim and not tell you the claim's denied. I've seen that happen before. So it makes things very complicated, very expensive, and very disheartening, not only for providers and hospitals and surgeons and anesthesiologists and primary care physicians, but also for patients. Because you have the same problem. You have no idea what they're going to pay, what they will pay and what they won't pay, whether your claim's going to get denied, whether they're going to say, oh, that provider's out of network. You don't know that, right? And so, my opinion is it's intentionally complicated to pit you and I, the patient and the provider, against each other, instead of where the actual, in my opinion, problem lies, which is transparency in the insurance industry.
How is that remedied? I mean, like, I again, we don't have to go down this political rabbit hole, but in terms of, like, I'm just going to use an example. Okay, my wife and I were going through this IVF process, right? And IVF, and I'm not being political here, IVF is not covered by most companies.
Health insurance, yep, correct.
Some companies out there will provide you resources to get the IVF procedures done.
Sure.
Initially, when I had to have surgery, that was covered under insurance.
Right.
But when we made the initial decision to be like, hey, we're going through this IVF process, it was just understood that nothing is going to be covered.
Cash only, yep.
Cash only. Everything is going to be out of pocket. Now, when some of the things were covered,
that's great, right? Yeah, you're happy.
You're like, we won the lottery.
Right,
yeah, it's fantastic. But, like for the patient to not know, man, is this procedure that I need? There's been movies made out of this, right?
Oh, yeah.
The procedure that I need is not going to be covered by the health insurance company.
Yep. Yeah. So what a lot of, and I'm trying to couch this in, third person, so I'm not specifically speaking to any experiences of my own. What a lot of companies do and what a lot of providers are now doing is cutting out the insurance companies completely. So you say, we're in northern Indiana. So let's say I went to University of Notre Dame and I'm Nuco Anesthesia Company. And I say, hey, Notre Dame, we practice at, ABC Hospital downtown. We want to be your sole anesthesia provider. We're going to cut out the middleman, and I'm going to charge you less than I would have charged the insurance company, and you're going to pay me less than you would have paid the insurance company, but we're both going to do better, right? So that's what a lot of hospitals and larger physician groups are doing. They're going direct to employers, especially if we've got big employers in the area, right? We got a bunch of RV industries in our area. Definitely could go do that. The other thing that's happening is, especially primary care, is going direct to patients, where they say, we don't take insurance. You want to see me under primary care, you come to me, you pay me a monthly fee. You can see me anytime, right? There's my own primary care physician in Indianapolis does it this way. And then what most people do is they just carry catastrophic insurance. So if you get in a car accident and you have to go to the hospital,
sure,
it's going to cover you for that, but it's not going to cover your medications. It's not going to cover your yearly primary care visits. It's not going to cover elective stuff. I mean, that's what's happening in the industry. Is that a solution? No, but I think it's a start.
So where are we, in terms of, you said it is a start, right? But where are we in terms of cost for physicians and providers? I think there's a misconception or a myth out there.
So cost to...
Well, meaning how much... So there's a misconception out there from patients.
That everything you pay goes straight into the pocket of the provider.
Absolutely.
Right, yeah.
So clear that... We're going to talk about salaries and anesthesia on our next podcast episode. So you don't have to go super in-depth on this. Yeah. But the misconception is, the doctor is pocketing everything. The clinic... The hospital is pocketing everything. That's not true, though.
Sure. So if you look across the board in the United States healthcare system, overhead expense, right? So for me to be able to pay for location and for providers and for all this sort of stuff, overhead is probably in the 35 to 75% range.
Does that include the insurance companies?
No, so what I'm saying is every dollar that comes into the practice
goes out.
35 to 75% goes to overhead, right? So paying the billers, coders, nurses, staff, keep the lights on, all that sort of stuff, right? So if you got a bill for $1,000, right, and the insurance company paid $1,000, right, that all came into the practice. Somewhere between $350 and $750 of that $1,000 is just to pay the overhead. Right, so
that's way more than what I thought.
Right, it's huge. Right, the overhead's huge, and so then after that, then some of that goes to the hospital, some of that goes to the provider, some of that goes to maintaining the practice itself. Right, you got to keep a little tucked away to maintain the practice. So when you see these exorbitant bills, not a huge portion of that actually goes to the providers. The majority of that gets lost in the milieu of paying for all of the other stuff that surrounds healthcare and costs so much money.
That is really interesting.
Yeah.
As a patient, you don't appreciate that part of it, right? You just think, hey, I'm going to the doctor and he's collecting hundreds and hundreds and hundreds of dollars and every visit or whatever, but that's really not the case.
Right.
But we're going to specifically talk about salary in our next episode.
All right.
Of Going Under, Anesthesia Answered with Dr. Brian Schmutzler. Really interesting topic. here on health insurance. We could probably talk for an hour
or 6.
About this topic. Let's dive right into our questions that was sent in from our listeners and our viewers on social media and on YouTube, Instagram, and Facebook. And, of course, his website is drbrianschmutzler.com. And if you don't know, he's also on Patreon.
Yes,
we talked about that last time as well. So check it out. All right, our first question, Brian, is what would you do if a patient starts waking up during the surgery and the surgeon yells at you? How do you manage that situation?
Oh, no, surgeons never yell at us. No, I'm kidding. Yeah, surgeons do have a reputation for being picky, let's say. So oftentimes, and I've joked about this with surgeons before. I mean, Adam CN, is a good friend of mine, and so we joke about this for sure. But when a surgeon yells at you, "Hey, the patient's waking up," what's happening is not the patient's waking up. The patient is responding to a stimulus. Okay, so whether that's the endotracheal tube, whether that's cutting, whatever. So we're very, very good about getting them back to sleep, which just means making them not respond to the stimulus. The amount of awareness under anesthesia is infinitesimally small. We're very, very good at keeping patients unaware of what's going on.
Sure.
And patients will react to a stimulus before they have any cognitive knowledge of what's going on. So when a surgeon yells about a patient waking up, they're not waking up. And I used to say this, and it ticked the surgeons off, so I stopped. But I used to say, they're not waking up. They're just responding to the scalpel. Okay. So, and that happens,
sure.
Not commonly, but also not super rarely that, let's say I'm sitting there for 15 minutes while they're prepping and draping the patient. I'm keeping the patient asleep, but I don't have them all the way deep as I need them to be for when you actually start your procedure. Right. So it takes about 15 to 30 seconds to get them deep enough that they won't respond to a stimulus. So, that happens. The surgeons yell, and then we have the same conversation about how they're not waking up. They're just responding.
You can hear over the music.
Yeah.
If they're blasting.
Celine Dion?
Yes.
Shout out to Adam CN.
Shout out to Adam CN for the Celine Dion. This viewer says, I had a 7-hour surgery. Did they speak to me to wake me or make me respond before ICU, or was I kept asleep? Please answer.
Yeah. So I don't know what procedure you had. I've done 7-hour surgeries where I wake the patient up and take the tube out, and we go to recovery or to ICU. If you had, open heart for 7 hours, I probably took you to the ICU totally asleep. If you had a craniectomy for 7 hours, I probably took you to the ICU asleep. It just kind of depends. So if you were intubated in the ICU, a lot of times that means that we didn't wake you up, right? We made sure that your vital signs were stable enough, and we took you over to the ICU, and then the ICU had you wake up kind of slowly from there. If I take a patient to PACU, I always make sure that the patient wakes up. Now, you're not going to remember that, and I think we've talked about this on a video before. You don't remember waking up. Even if I wake you up in the operating room, a lot of times you're not going to remember waking up. It's going to take you 30 to 120 minutes for you to have any awareness of the fact that you're awake. So I can't answer your question specifically without more details. My guess is if you went straight to the ICU, they didn't wake you up until you were in the ICU. They got you kind of all settled in, got all your lines and drips and all that sort of stuff ready to go, and then they slowly weaned off the anesthetic to wake you up.
All right. Thank you for the question. Thank you for the answer.
Sure.
Our final question comes in the form of, what are important considerations in deciding between EM, which is
emergency medicine,
and anesthesia?
Yeah, so this goes back to something we talked about a while ago. When you go to medical school and you kind of take that path of what are you going to do, are you somebody who does procedures or doesn't do procedures, right? And so emergency medicine and anesthesia fall in that procedural realm. The reason people are drawn to both emergency medicine and anesthesia is a few different things. Number one, immediate results, right? I put a patient to sleep, they go right to sleep. That's not like primary care where I give you a medicine and then I check again in a month to see if the medicine worked. Number two, we don't carry our own patient load in emergency medicine or anesthesia. So patients come in, you treat them, you send them home. You're not likely to follow up and see them again. And number 3 is shift work, right? So it's not, I'm on call for a patient to call me with a problem at 2:00 in the morning. Who's my patient long term? I work 7 a.m. to 7 p.m. and then I go home, and there's somebody else in terms of emergency medicine. There's somebody else who takes over. Or in terms of anesthesia, I did cases during the day. If I'm not on call, my colleague is going to be on call and take care of the patients who come in. So that they're similar in a lot of ways. And so why decide anesthesia versus emergency medicine? For me personally, the physiology and pharmacology of anesthesia was super interesting, and that's sort of my background. So I really liked that, as opposed to emergency medicine, which is a little bit more diagnostics and, kind of figuring things out, looking at radiographic films and looking at labs and that sort of stuff. So I liked both, but I really liked the physiology and pharmacology of anesthesia. And anesthesia is a little bit more hands-on in that every patient that I see, I'm doing a procedure, as opposed to emergency medicine. There might be 50, 60% of patients you do just diagnostics, and the other 30 or 40 or 50% you do procedures.
And if you want to see that episode and where you talk about,
I can't remember what episode that was.
I think it was episode
2 or 3.
1 or 2. Yeah, right. Talking about deciding on anesthesia versus the other professions. I get to do the YouTube thing where you link it below.
Oh yeah, link it below.
Link it in the description. Subscribe.
Yeah.
Subscribe to Dr. Brian Schmutzler's channel as well. We haven't done that yet. Yeah. But interesting things here. I mean, when it comes to answering your questions, Dr. Brian Schmutzler is the best at it. He looks at, I'm not joking, he looks at every single comment and question, and if he doesn't, I do, and if I don't, his wife does. So,
that's right.
Just telling you, we're looking at your questions and comments, and we are answering them to the best of our ability. Great stuff here, Brian. In our next episode, we get to find out how much money you make.
There we go.
So that,
or do we?
or do we? This is Anesthesia Answered with Dr. Brian Schmutzler. Of course, subscribe to the YouTube page, and of course, all his other social media channels.
Thanks.
Thanks.